Hello, namaste, good afternoon, everyone. I'm your Master of Ceremonies, Mayuri Malankar, and it gives me immense pleasure to welcome you all for our webinar on Affordable Liver Transplant Conclave 2021, organized by the Praveen Agrawal Foundation, a philanthropic organization that is dedicated to making liver transplant in India affordable, accessible, and available for every child in need. I welcome all the eminent panelists and the moderators who have joined us this afternoon to make ALTC 2021 a success. Since its inception in 2016, the foundation has supported more than 250 children to get a liver transplant done and led a healthy life thereafter. Every year, we hold a roundtable to bring together the best minds in the field of pediatric liver care and prevention to provide valuable insights, discuss the challenges and outcomes to make pediatric liver transplant affordable and accessible to all. The theme of this year is current developments in the field of pediatric liver transplant. For the past 2 years, we have been meeting you all on this virtual platform due to COVID restrictions. But now the world is changing, gearing up to bring life back to normal. The vaccination drives, adapting to good hygiene habits that are the proof that we are not letting the virus win over us. So like every year, we are here to connect and discuss with you all the innovations and happenings in the field of pediatric liver transplant. Well, this is the fourth edition of ALTC and it makes us immensely happy to see all of you participating in this webinar despite the festival hangover. Now, I would like to request Mr. Praveen Agrawal, the founder of the Praveen Agrawal Foundation, Vice Chairman of Sterlite Technologies, Chairman of Sterlite Power, to share a few words and welcome the dignitaries. So, welcome.
Thank you, Mayuri. Good afternoon, everyone, friends. A very warm welcome this afternoon to every one of you. It gives me an immense pleasure to welcome all of you to the fourth edition of today's Affordable Liver Transplant Conclave. 2 years back, when COVID-19 pandemic hit us, little did we know that our lives will be affected in ways beyond our imagination, and our computer screen will become the window to the world. This is the second time in a row what we are organizing Asia's biggest pediatric liver transplant conclave virtually because of the ongoing COVID restriction. But I hope we get to meet each other in person soon, given the ongoing vaccination drive are helping us to fight the virus. Getting ahead with the theme of the year's ALTC 2021, which is current developments in the field of pediatric liver transplants, we have with us eminent speakers and thought leaders from across the globe to share their perspective with us. I'm happy to tell you that since our inception in the year of 2016, we have till date supported more than 250 pediatric liver transplants and initiated support groups for the welfare of patients and their families. I'm happy to tell you that at TPAF, we are aiming to touch 1,000 lives in a year and help pediatric liver transplant to get a new lease of life. A healthy child with a healthy liver can do wonders for the society and for the country. Friends, there is this famous saying by Helen Keller, alone we can do so little, but together we can do so much. We are very happy to tell you that we are working closely with PLT collaboration project with Rotary Club of Delhi South Central. We have some esteemed members of the club with us in the audience today. While we will try our best to give pediatric liver transplant patients the support and care they need, we are open to collaborating, strategizing, and increasing our help and outreach to people who need us. Lastly, I would like to extend my heartfelt gratitude to all the doctors, healthcare professionals, and our panelists who have come together in today's to make ALTC 2021 a great success. I'm confident that the upcoming discussions will give us a critical insight of making liver transplant accessible and affordable for everyone. Now, friends, I would like to invite shortly to share their thoughts of the wisdom of with us. And also, friends, I'm thanking you once again till we meet again in person once we complete this today's event. Thank you.
Thank you so much, sir. Thanks a lot. Friends, as we know, TPAF is the brainchild of Mr. Praveen Agrawal, and the organization started with the sole mission to make pediatric liver transplant affordable and accessible for everyone. I'm sure you might have a lot of questions about TPAF, like what we do, what our work looks like, the lives we touch. But throughout this event, we'll be discussing all these things in detail. But for now, before we move ahead, here is a small AV that will help you to understand and know us better. Also, you can visit our website www.tpaf.in for more information. But first, let us look at this video where we let the smiles and the joys in the face of these kids do the talking for us. So let's watch this AV together.
उसके जन्म से ही लिवर रिलेटेड एक बीमारी थी, उसका नाम था बिलियरिया एट्रेसिया। तो डॉक्टर ने कहा कि उसकी लिवर ट्रांसप्लांट करना पड़ेगा। तो हमारे पास उतने पैसे भी नहीं थे, कोरोना जैसे ऐसी दिक्कत वाली दिन चल रहे थे। अग्रवाल फाउंडेशन का मैं तहे दिल से शुक्रिया अदा करना चाहता हूँ।
इसको टायरोसिनेमिया नाम की बीमारी थी, इस वजह से उसका लिवर ट्रांसप्लांट पिछले दो महीने पहले हुआ। हमें इस ट्रांसप्लांट के लिए द प्रवीण अग्रवाल फाउंडेशन उनकी बहुत सहायता हुई। थैंक यू।
हॉस्पिटल में अनुराग सर ने हमारा बहुत हेल्प किया है, उन्होंने लीवर ट्रांसप्लांट किया है इसका, और उसमें से प्रवीण अग्रवाल ने भी हमारा हेल्प किया है, तो उसके लिए हम उनको धन्यवाद बोलना चाहते हैं बहुत बहुत।
Well, a big and a huge round of applause for Team TPAC for the job, for the wonderful work they have been doing. Kudos to you. And once again, congratulations. We hope to touch many more lives in the future and help patients of pediatric liver disease live a fulfilling life. Well, getting ahead with our agenda for the day, I would now like to request Dr. Neelam Mohan, who's a director, Department of Pediatric Gastroenterology, Hepatology, and Liver Transplantation at Medanta, the Medicity Hospital of Gurgaon, to join us. Well, talking about Dr. Mohan, she pioneered therapeutic endoscopy in newborn and young children in India. She's a BC Roy National Awardee 2016 by President of India, a doctor par excellence, widely known for her pediatric liver transplant and hepatology contributions. She is an advisor for Arogya Bharat Pradhan Mantri Jan Yojana from 2020. Well, before we begin with the panel discussion and her talk, I would like to tell our viewers and the eminent panelists that since we are pressed with the time, we would now we would like to try and stick to the given timelines and wrap up the discussion within 20 minutes. 5 minutes before we end the talk, we'll be flashing across the timer on your screen to remind you that we are nearing the end of our insightful session. Okay, so I would like to now inform our viewers also. We have some viewers watching this event through YouTube. Some are on Zoom chat box, Zoom. So Zoom viewers, you can use the chat box if you have any queries. YouTube viewers, you can use the comment section if you have any queries, because after the panel discussion, we'll be having a Q&A with the doctors. So now I'll request Dr. Mohan to take over the talk and start with the first panel discussion and her talk as well. So Dr. Mohan, over to you.
Thank you so much for that lovely introduction and the video which you gave. And it is definitely my privilege to be the opening person for this ALTS 2021 program. I would take this opportunity to introduce my panelist. And one of my first panelists is Dr. Sudhindra. He has been the first liver transplant surgeon from the state of Kochi. And we all know his excellent work, and he has done by now more than 800 liver transplants. And I remember the days when Sudhindran had come and he was starting his pediatric transplant program. I must compliment all of us should never have ego when we don't know anything. He used to ask about some medical things because he was setting up the program for pediatric liver transplants, and he's done a wonderful job. With that, I have my next panelist as Anurag, the young guy from Mumbai, rocking city. And he's in global, and he's famous for not only his liver transplant work, but pioneered quite a lot of things in pancreas too. And he leads the pancreas and the pediatric program at global. And the third panelist is a colleague, similar person like me, a pediatric hepatologist and liver transplant physician. If I may call myself rocking in the north, he rocks a lot in the south. And he is at the Rila Institute and a very dear friend of mine. We discuss a lot about a lot of things, medical, non-medical. And so it's absolutely my pleasure to have the three panelists with me. And can we share the PPT, Aishwarya, where I think we can use the some questions and some introduction. So what I wanted to introduce is that when we talk about the COVID facts, now the serosurveillance in India has shown that though the serosurveillance was similar as in adults in children, but the frequency, we did not have confirmed cases as many as in adults, suggesting that clinically the disease is more mild, and very occasionally you might end up with a severe or a moderate disease, and especially those with comorbid conditions are what we are worried about. So how is it different from adults? One was the severity. Of course, we differ in our treatment protocols too. We don't use rituximab and CT chest like as much as in adults. But yes, we do consider anticoagulants and steroids in our severe cases. Something which is unique to pediatric patients and COVID 19 is MISC, the multi inflammatory syndrome in children, MISC-C. And here we divide it into with shock, without shock, and then we decide whether we want to give IVIG or steroids. And one more difference in children less than 5 years, we don't, the Government of India guidelines do not suggest a mask to them. Now, there has been so much of a difference. When we started, we call it COVID-19. And then by 20s, we were talking about this disease is associated with severity in liver patients, etc. And then as we marched, we started saying, no, it is more for cirrhosis. And then as we march forward into 2021, we have said, I'm talking about adults too. They talk more about those patients who have cirrhosis and comorbid conditions that they have. So there has been a change from what we started and then we moved forward. How does the COVID-19 affect the liver? It is not only the direct effect of the virus, but the cytokine storm, the hypoxia, the drugs that we use in them, and to add on up to it, if there is a pre-existing liver disease. The newer theories is talking about the permeability in the gut and, the leaky gut, dysbiosis, all this having an impact through the portal circulation into the liver. And I am talking only about liver disease. How does it occur? How these morbidities are giving rise to in COVID-19. Now, Naresh, as a pediatric hepatologist, you would be seeing a lot of chronic liver disease patients. First, before I just talk about transplant patients, we need to understand about these chronic liver disease patients. What do you think is, how different, if a parent comes to you, what would you say? How do you prevent and how do you manage? Something special you would tell them? You'll have to unmute yourself, Dr. Naresh.
I think there are certain routine guidelines that we tell about that essentially parents to vaccinate themselves so that the disease that they can contact to the child becomes less. And with the severity of disease, I think the more severe disease, when they have COVID, the impact is much more. And a lot of papers have shown particularly the impact is more on children who has NASH sort of cirrhosis. But fortunately in India, we don't have much of that cohort. I think the cohort we have children with ascites, malnutrition. So that sort of cohort we have. And another cohort what we have is children who are on steroids, autoimmune liver disease, who has been on steroids. So most of the time parents ask about how to prevent, whether we can stop the steroids, decrease the steroids. I think there are a lot of guidelines that has come to that part as well, that the disease, a lot of papers have shown that the disease is not as severe the disease is severe that compared to the normal children for mild to moderate liver disease. But when they have a severe form of liver disease, the impact can be more because their reserve is less, they can't tolerate much of hypoxia, and that's the reason. So we will tell them, the children who has a severe form of liver disease, to isolate them, to keep them away from children who has respiratory illness, vaccinate the parents to be vaccinated, and parents to be careful in handling these patients. And patients who are on steroids, not to tamper with the medication, just to continue to speak to the doctors and continue with the same dose of medications. I think this would be the advice by me.
What is the impact on the enzymes that you would see, or is it, in COVID-19 in these patients? Do the parents need to look for jaundice, or what really is the impact of it, both biochemically, histologically? What do we understand now?
Essentially, we know that this COVID virus attaches itself to the ACE2 receptors and multiplies. And liver cells has a lot of ACE2 receptors, but fortunately, the COVID virus is not a hepatotrophic virus, and nobody has actually cultured the virus from the liver. So whatever impact it does on the liver is a secondary phenomena. And usually what we see is a slightly raised enzymes, ALT, ALT, not even causing twice of upper limit of normal. And only in severe cases, we look into jaundice as a cause. And most of the enzymes rise can be secondary to the drugs, but in children we don't use much of the drugs what we recommend, like to the adult
Yeah, that
population.
was my next question, that, a lot of drugs that are being used in COVID, azithromycin and amoxicillin, clavulanic. So I would expect you to give a word of your wisdom, about the drugs that you need to be careful, especially in patients with liver disease.
Now, particularly, I think the NSAIDs has been told that it can cause trouble with regards to children who has COVID related illness, but apparently any drugs can cause. And ibuprofen is one of the drug. Initially, there was a big discussion about it causing trouble, but recently the FDA has said that uh, they said there is no concrete evidence that this drug alone can cause. But there is, as you have put up in the slide, there are a lot of drugs which can cause trouble, the enzyme elevation. But as long as the enzyme elevation is not 2 times the normal above the limit, I don't think there is any reason why we can't continue those.
Yes, that was a very important point, that sometimes when we use the medicines which are not even proved, like azithromycin and moxiclavulanic, we've been just using them. It's a word of caution. They might rather do harm to your liver rather than be beneficial to COVID-19. So that was a really good advice, Naresh, that you gave us. So when we're talking about COVID and pediatric liver disease, this was a beautiful paper which came out from the Apazal group and Dr. Sareen, who's been heading in this COVID task group with Apazal. And surprisingly, the data which they had shared was that in patients with child-seized cirrhosis, there was 33% chances of severe disease and 41% of mortality. And those with liver transplant had mortality 18.1%. So I would just restrict the question to you, Naresh, that what is your experience of COVID-19 in children with liver disease? Transplant, I'll ask some other panelists. In liver disease, like cirrhotic, like this data which the adults have given, 33% severity and mortality 40%. What are your thoughts about it?
Personally, when the COVID hit us and when there is a lot of discussion going on, I told my ICU people that you can expect a lot. The children who came with trouble with liver disease with an acute COVID is much less. Probably in the last 2 years, maximum 15 patients getting admitted, and probably around 10 patients who came to the OP with a very mild illness and went home. And even of the 15, moderate disease, and we don't need to do anything. After 3 days, 4 days, the fever settled and they got better. Personally, I didn't experience any mortality in.
Right. I agree with Naresh, and I'm just sharing my slide from Jan 21 to July 21. Patients who were total 112 patients that we had. Of them, we did have around 12 patients who presented with that. 2 of them had come with INR more than 2, and hepatitis E, Wilson's disease, autoimmune in those patients. But only 1 actually had to be moved to ICU, and there was no mortality. most of the patients where we were able to manage in the ward itself, the moderate diseases. So our experience is almost similar in that 6 months data, which I presented of 12. So I think, Anurag, you've been sitting calmly. It's time to talk to you too. We this just like our data, similarly, there was this beautiful survey. I really enjoyed reading this paper from Italy. What they did is they use a questionnaire of which 95 people responded to the questionnaire, which is very interesting, unlike if you and me send a questionnaire. And they did say there were 26% cirrhosis in this questionnaire and 4% were listed for liver transplant. And they did say that in pediatric patients, an underlying liver disease does not represent an additional risk factor for severe COVID-19. So I'm quite glad what Naresh talked about in South and I talked about in North. We did have experience of a survey from Italy, and similarly a PubMed interview, which did talk about majority of the patients having raised in the enzyme, and you need to continue with the normal care that Naresh was saying, that autoimmune liver disease, please do not stop their steroids, and tacrolimus do not reduce, because I remember initially I getting a lot of calls whether we should, and when the patient would get it, let me be honest, I was also worried whether I should stop mycophenolate and lower down the immunosuppression, and then subsequently we realized that cytokine storm anyway, they were giving steroids and all that, and so there was no logic of reducing, rather it may be quite protective. So I was also using more of than steroids, and then we became bold subsequently with other patients. So Anurag, what exactly would you think that he was hinting in his talk? Naresh said that unlike the West, we do not have so much of NASH associated diseases, and that's one line he rattled. So my question to you is that, are obese children predisposed to severity or metabolic disease or COVID-19? What are your thoughts on these?
So thank you, Dr. Mohan, and definitely the obese children are much more predisposed to a severe form of COVID. And as you have shown on your slide, that the prevalence of metabolic liver disease or fatty liver disease would be as high as 34% in the obese population, as compared to the non-obese of around only 7%. And more important is that the COVID-19 illness could be more severe as compared to the rest of the population, and the risk could be as high as 6-fold in them.
Yeah, so that's interesting, 6-fold risk in obese. So I think Anurag is giving a message all of us should take out time, like Naresh, passion is nutrition. We all need to talk about nutrition in children. It's very important, irrespective of whatever field you are, hepatologist, surgeon, utilize this opportunity. So what has been the impact of the COVID pandemic on children, Anurag? I mean, have you been seeing some different impact, like their tendencies?
Correct. So, I mean, definitely with less and less physical activity, they are tending towards obesity and other issues. Then, as transplant surgeons, I mean, we have had separate pathways for their healthcare, as well as the challenges have been increasing use of telecare or telemedicine to ensure a good follow-up of these children. I could share, like in our own cohort of 60 patients, we had one peri-transplant patient with COVID with a very severe illness who couldn't make it. And the rest, we had around 5 patients who did develop mild symptoms, none of them requiring hospitalization, and did very well. So,
can you also answer this, that how different, COVID patients with liver disease and liver transplant, some guidelines, something you would follow in your management, which have been provided as management besides the telemedicine, etc.? How do you deal with your patients with COVID-19?
Correct. So as like we would do their baseline workup, including their D dimers, ferritin, and all of it, and stratify them into mild, moderate, and severe disease. Only the children with severe disease would require some reduction in immunosuppression. Steroids definitely help, so we would definitely keep steroids on board.
And suggestions about, like special, you would want them to be on any other. So is there any difference between tacrolimus and mycophenolate that you would want to taper off in these patients?
So, as you pointed out, that mycophenolate being an anti-proliferative, we always try to reduce it, but steroids and tacrolimus would continue almost the same dose.
And was there a difference in patients? You said somebody didn't make it. Was that a liver transplant patient?
Yeah, that was a patient.
In the first 3 months of transplant or 1 year, is there any difference in that?
Yeah, absolutely. So this was a kid within the index admission. So probably was harboring or having COVID in the intubation period and manifested by around day 5, day 6, and continued to have severe lung disease and did not improve. And as you mentioned, the rest of our patients who were beyond 3 months and especially beyond 1 year, almost all of them had just mild COVID disease, sometimes with a diarrheal presentation, and all of them did very well.
Yeah. So Sudhintaran, what I want to ask is, there were so many deaths that was happening during COVID, and so many patients waiting for liver transplant. Did you have the courage to use this livers for organs, as organ for patients?
You mean from donors who recovered from COVID, you mean?
Yeah, either both COVID-related death or donors who've recovered. What was your protocol to accept them as donor?
Yeah, so basically during the first wave, evidently everybody was scared of what would happen if you take a donor, if you take a COVID positive donor, either diseased donor or live donor. For two reasons. One, if it's a live donor, you don't know what's going to happen to the donor from a surgery, because we all know that patients who have recovered from COVID, they don't come back to their original level for at least 7 weeks from the time of onset of COVID. So we're worried about the donor. Second, of course, is transmission of infection from the recipient to the donor. Actually, there's not been a recorded case of transmission from a recipient donor yet, as I'm aware.
Yeah, I think even Naresh mentioned that probably the virus was not isolated.
So I've got the data. So basically, just looking at livers alone, there were 21 liver transplants done from donors who were COVID positive, of which 7 were diseased donors and 14 were live donors. So even there's been quite a few kidneys, and even 6 hearts were there. And believe it or not, there were actually 6 lungs as well from patients who recovered from COVID. All of whom did well because they had very mild infection. In the liver patients, nobody developed COVID positive per se, although there was one patient who had possible COVID hepatitis. From the liver biopsy, there was some suggestion that could be a COVID hepatitis.
I would, because of shortage of time, I would need to give a message because a lot of audience.
I think as of now, the thing would be if for a live donor, after 4 weeks, you're relatively okay if it's a mild COVID. If it's a severe COVID, I think we should wait for 3 months.
Okay.
Diseased donors, within 3 weeks to 3 months, you don't have to do the COVID. You're okay to take up the donor if they've been fine.
Yeah, that was a beautiful message. So all of us, we know that 2 vaccines have been now DCGI approved in children, Covaxin from 2 to 18 and Zydus COVID vaccine for 12 to 18. Now, when the experts were giving they forgot to mention about liver. They talked about asthma and kidney. So what is your thoughts about these patients of liver disease and liver transplant? Should they be priority?
Should they be?
priority to get the vaccines if when there is
I think so, because now there is some soft data that post liver transplant patients, their immune response to the 2 doses of vaccine is not good, and there is a recommendation to use a 3rd dose. So definitely they should be prioritized. We recommend that they get the vaccine immediately 4 weeks after the transplantation, and there is a recommendation to go for a 3rd dose.
So you agree, and I've been working. I was fortunate to be with the advisory group, and I did give interview on the same day to the Z News, and I said, and I passed on that please consider these patients also, because parents are waiting to get that. And the last question to you: what was your experience of COVID-19 outcome in liver transplant patients, while the others have shared about liver disease? So in your liver transplant patient, did you, what was your experience?
So post liver transplant, within the first 3 months, for some reason, we had only 4 patients who got COVID. And thankfully, they all did okay. However, there was one donor who got very severe COVID, became ventilated for a long period. Fine, she recovered, but she took 2 months to recover from that. Thankfully, she's okay. But post 3 months, after 3 months, we got 71 patients who had COVID, of which 3 died because of the COVID. About 7 or 8 got COVID, the cocktail antibody cocktail. Children, there were 14 children, all did well. There were no problems with that. Only 5 of them had to be escorted to hospital. Others were absolutely fine. So generally, it was not as bad as we thought it was.
So I totally agree. What a coincidence. We've not talked to each other, South and North. Even I had a liver transplant, 13 patients, and all those who were managed at our center, none of them died. But sadly, 2 of my patients were in Bangladesh, and I don't know whether the care, these 2 patients had MISC and both children died. So maybe there was more awareness in our country that we were more alert. We didn't hear about children dying with a post-liver transplant with COVID-19 from all Mumbai and Kerala and Chennai and my center. But 2 patients who were transplanted at our center died with MISC. So we do see that. And I would really thank my panelists. And if there are any questions, I would request you all to just put it in the group, and we will, answer in the chat box because of shortage of time. Similar data is coming from other countries that in transplant patients, this is there. And Sudhintaran has talked about the difference between pediatric and adults in the outcome of that. Thank you so much for giving this opportunity to 4 of us. And I thank on behalf of Sudhintaran, Anurag, Naresh, and myself, and congratulate TPAP for this opportunity. And over to the organizer.
Thank you.
Thank you.
And you all please answer in the chat boxes. I'm going to reply in the chat boxes and get back to you.
Sure.
Thank you.
While they are taking time, maybe if organizers come.
Thank you so much, Dr. Neelam Mohan, Dr. Anurag Shimal, Dr. Naresh Shanmugam, and Dr. Sudhindran for such valuable insights and in-depth discussion on management of pediatric liver transplant amid the pandemic. It was such a rich learning experience for all of us. Thank you once again. Moving ahead, ladies and gentlemen, I would like to request Dr. Sonal Asthana to take the talk forward. Dr. Sonal Asthana is a senior consultant, Department of Hepatobiliary Surgery and Multi-Organ Transplantation, Aster CMI Hospital, Bangalore. He is a highly trained hepatobiliary and transplant surgeon with work experience in leading centers in North America, UK, and India. He is also a recipient of the highly acclaimed BMJ Medical Excellence Award. And before we begin with the panel discussion, I would once again like to remind our viewers and the panelists to stick to the given timelines and wrap up the discussion in 20 minutes. And just like the previous session, the timer will be flashing across your screen 5 minutes prior. And to remind you that how much time is left. Viewers, come on, ask your queries in the comment section if you are, watching this through YouTube. And if you are on Zoom, then please post your queries in the chat box. All right. So let's move ahead and over to you, Dr. Astana.
Sure. Thank you so much, Aishwarya, for that kind introduction. It's lovely to see everybody. Thank you so much, Praveen Agarwalji, for hosting this for the fourth year in a row. I think that having been part of this for the last 4 or 5 years, we have had the privilege of seeing how the conclave has actually evolved over the last so many years, and now has become sort of a lodestar for not just technical discussions, but also discussions that impact healthcare policy. And I know that a lot of people who actually are involved in funding transplant keenly follow the progress of the conclave to see where their funding dollars are very well spent. And all credit to Shri Agarwalji for actually bringing this to fruition. So thank you again to Dr. Neelam Mohan for that scintillating session. I mean, that's very educational, because it's always very fascinating to hear about what COVID is doing in the pediatric transplant space and what our experience has been. So we've all learned a lot from that. I think our next session will sort of segue really well into our discussion, because in the context of a reduced donor pool because of COVID and because of sort of lower traffic in general, we find that a lot of our patients are disadvantaged with the view of transplant, especially in the pediatric context. So to sort of answer these questions, we have 3 excellent panelists today, most of whom do not need any introduction to a transplant audience. Firstly, we have Dr. Vivek Vich, who is the director of the liver transplant program at Fortis Memorial Hospital and the Fortis hospitals in Delhi and across India. Where Dr. Vivek is an acclaimed transplant surgeon. He's one of the youngest surgeons to perform a large number of living donor transplants, both in the adult and the pediatric space, and he's recognized as a thought leader in transplantation, not just in India, but abroad. We also have Dr. Heinrich Mergenthal, who's a consultant transplant surgeon from the University Hospital Birmingham. And Dr. Heinrich has the unique distinction of not just being a transplant surgeon, but also having seen one of his pet research ideas go from lab to clinical use. And he's kind of pioneered, if I may say so, normothermic machine perfusion, along with teams in Oxford and Birmingham, to reaching a stage where machine perfusion is not just used to preserve livers, but also modify the conditions of livers. So this has opened a very interesting door into increasing the donor pool, not just for adults, but for children. So we're hoping to hear some insights from him. And then, of course, last but not the least is Dr. Prashant Bhangi, who's a senior consultant in liver transplantation at Medanta, the MedCity Hospital, which is one of our largest liver transplant programs in India. He's also internationally renowned for being a true academic transplant surgeon. And he is perhaps someone who we are looking to give some insights into how we can modify our allocation policy to decrease the disadvantage that our pediatric patients face while waiting for a transplant. And this is a particularly challenging topic. I've chosen it for him because I know that he'd be able to put it in the context of India, where we have a hybrid of a DDLT and an LDLT program. So no one answer fits us all. So I think I'll kick off firstly with Dr. Vich. Vivek, thank you so much for joining us right now.
Thank you very much, Sonal.
Yeah. So Vivek, I think if to just sort of set some context here, what is sort of the pediatric liver transplant burden that a country like India would be looking at, and from your experience and from the data that you have seen?
Sonal, I think very, very relevant question. When we did our last conference, we also pointed this out, that pediatric load in a country like India, the number of transplants we do, especially of Indian subcontinent, are very few. if we look at our numbers, then not more than about 5 to 7% cases are pediatric cases, true pediatric cases, less than 12 to 14 years. Now, I have, practically speaking, let's come to practical scenario. I hardly see any Indian patients or the parents who are very keen in getting the transplant done of the pediatric or their kids which are quite young. This might be because we don't have a good pediatric program, but I think this is more because there is lack of awareness about outcomes of pediatric transplant. People really don't know what's the long-term outcome. And if you compare this scenario, Indian scenario, like total, I think we do around 1,500 transplants. Out of them, I think more than 90% would be adult transplants rather than pediatric transplants. I worked in a different scenario in Delhi, in Tamil Nadu. In Tamil Nadu is a different scenario where government funds the transplant, especially of the pediatric patients. I used to do 4 to 5 transplants every month, pediatric transplants there. So I don't think there is a lack of number of patients, but the chain of events after that, whether it is awareness or it is, a monetary issue or any other issue, I think those are problems we should handle first and then increase the volume of pediatric transplants. Of course, DDLT or disease donor is a limiting factor, but there should be some chunk of patients, especially for living donor transplant also. So I think we lack that awareness in pediatric population and amongst the parents that liver transplant is a life-saving procedure, especially for children, has a very good long-term outcomes.
Sure. I mean, two very good points. One is awareness. Second is funding, which is probably the big difference, say, between Delhi and Chennai, the two cities where we practice. Now, in a living donor context, what are the surgical strategies, perhaps if you could just list 2 or 3 of them, in which you could make organs more favorable for maybe children who are very small, or so that we get a good size match? Because given your vast experience, if you could just list them out, because it's not a completely technical audience, so perhaps just sort of 2 or 3 of them.
So because it's not a completely technical audience, I would start by saying that liver donation is of 2 types, living donor as well as disease donor transplant. In living donor transplant, as compared to adult donation, where a person donates to an adult patient, the donation process for a pediatric patient is much safer because we take a much smaller chunk of liver from the donors. It's typically about 10 to 20%. We just take a small segment. Complications are much less. Procedure is much simpler. And so this thing should be kept in mind, that it's a safer procedure to donate, even if we consider living donor transplant, number 1. Number 2, because of advent of minimally invasive surgery, I think it is very well suited to pediatric donation group, because it's a small liver, a chunk of liver which can be easily taken out by laparoscopy or by robotic surgery. I think these are very important key points which will help families to decide that they have to save the life of child, and it's easier to donate, it's safer to donate. I think this is what we should percolate till the time we have awareness of disease donors. There are more disease donors. When we can jump into more of split liver transplants, more of machine perfusion, where we can split the liver into pediatric and adult. So these things will come definitely. But first thing first, I think awareness and safety of donor has to be in the minds of parents and pediatric population.
So thank you, Vivek. Those are 2, again, well-made points, actually. The role of minimally invasive, and also a very nice sort of lead on to Heineck, who comes on next, on about machine perfusion. So, I mean, Heineck, this is something that has really revolutionized transplantation. All of us are very excited about it in the last 4 or 5 years, probably one of the first big things to come out in several decades. Would you mind just talking us through this technology? Your sound, Heineck.
Thank you so much for your kind invitation to participate in this meeting. And indeed, machine perfusion is just changing the liver transplantation landscape. And in the Western world, when we've seen a dramatic decrease of quality of deceased donor, it's a game changer, because at this moment we are using donors which wouldn't be ever considered 5, 10, 15 years ago. So that's why the machine perfusion really needed to come, just to make the transplantation safer for our recipient. What the machine perfusion does, well, we are replacing the ice box with a technology that keeps the liver sometimes alive, sometimes just sleeping, but it provides it with oxygen and quite often nutrition. So we do have several types of machine perfusion, and the main differences are based on the temperature. So we can have warm perfusion or cold perfusion, and every type of perfusion. And in the past, we sometimes seen them as competing technologies. But the more and more we know about the new technologies, the better we just understand that there is more like personalized or tailored approach to each kind of donors. On the slide, you can see on the screen is that really was changed in the Western countries with the donors. So these days, majority of the donors are dying on intensive care unit with some underlying condition, and age or obesity are really frequently present. I mean, in India, it's probably not as big issue, but in India, there may be other challenges. I think there's a world-leading experience in transplantation and hepatology side of the transplant program, but there may be probably some scope for development of the organ donation. And then where I see probably the opportunity for machine perfusion, because many of the donors are probably, I don't want to say purely managed, but if something happens in the small peripheral hospital, it takes time before the donors are managed. And of course, the distances in India are massive. To reach the transplant center is just taking lots of time. So that's where the machine perfusion can definitely help. In the next slide, we can really see what the machine perfusion does. So the liver is like, on the picture you can see like a battery, and if it is a good liver, it can last in the ice box for 8, 10, 12 hours. But these days we are getting livers which are kind of like partly discharged batteries. Okay, so we just really need to get them back and to get them better. So the most common one, which has been really established in the UK now as a kind of standard procedure for marginal livers, is a normothermic perfusion. So what it does, we can start a perfusion in the donor hospital or at the recipient center. And initially, we thought that the donor hospital is really the place to do it. But there are real logistic challenges. So these days, majority of machine perfusion does happen at the recipient center, which is much easier. But of course, having said that, it works in the UK, which is much smaller country. I'm not sure how this would be transferable to India. So what we do, we put a liver on machine, we see if it can work, because the machine keeps the liver alive. So we see how is it perfusing, if it is metabolized lactate and glucose, is it producing bile, and it just gives us assurance that even if we use liver with long cold ischemic time or some unfavorable features of the donors, that it's still, we won't put our recipients at risk. Okay. Just over the last 12 or 24 months, new technologies become available, in particular for non-heart beating donors. It's a type of donor pool which is really have probably the biggest potential for expansion. And the reason which is relevant for pediatric programs is that these donors are usually of younger age. So these do not have many underlying conditions. And the reason why they do not work very well in long term, there were a problem with bile ducts. That was the Achilles heel, and you could do successful transplant, but the transplant failed because of narrowing of the bile ducts later on. So the new technologies, which is either cold perfusion, that was published recently in New England Journal of Medicine, can dramatically decrease of the non-anastomotic biliary strictures. Or even better, perhaps, is to change a non-heart beating donor into kind of like heart beating donor with a normothermic regional perfusion. So these are really exciting developments, and I think it will bring new opportunities for pediatric transplantations. Yeah.
That's excellent. I mean, that's an excellent summary, Heineck, because certainly modification will increase this. And Dr. Roberta Angelico is going to speak to us a little bit about the Italian experience of not normothermic, but hypothermic perfusion, and perhaps how it can be used to split organs as well. So I'll come on to Dr. Prashant, who sort of gets probably the most difficult talk, because it's not purely a technical discussion. Dr. Prashant, I mean, the questions here are, one is, how do we expand the donor pool to favor pediatrics? Because we know that pediatric patients are disadvantaged when they wait for organs across the world and India as well. So firstly, what's the scale of the problem, and what are the solutions? I think that's probably the two things that we'd like to see from you.
Yeah, thank you, Sonal, I think for that. And I guess the key point, one of the key points, is that primarily the pediatric age group is an underprivileged population when it comes to disease donor liver transplantation. I had some slides on, if you could just play them. We now have an Indian liver transplant registry that is underway. Sonal also is a key part of that registry who we've just started. I can say it's in the infancy, but whatever data we have as of now from 2017 to 21, if you look at the slide, the proportion of disease donor liver transplants that have happened in India over the last 3 to 5 years is only about 5% of the total number of transplants that have happened. And if you look at the right side of the slide, in fact, you'll find that among the LDLTs, the proportion of pediatrics is just around 18%, and it's even lower when we come to the DDLT setting. So it's just around 6% out of the total DDLTs that have been performed. Now, if you go to the next slide, I think that the other thing that we need to look at is that there is a longer wait list time for pediatric patients. And why is that? That's because of the scarcity of size-matched whole grafts harvested from young size-matched donors, which in simple terms mean that we have few pediatric DBD or DCD donors who could donate livers to pediatric recipients, and therefore the size match is an issue. The second is that normally you want to give the best livers to the pediatric population. So even if it is a split liver, you want to split it from an ideal donor. So a donor who is less than 45 to 50 years of age, stable donor, short ITU stay, normal LFTs. And what is happening today is you're getting more and more of borderline grafts. So you're not getting those optimal grafts. And therefore there's a reduction in the number of livers which are actually suitable for splitting. And what does this all translate into? There is a hesitancy of putting pediatric patients on the waiting list in India. So I think that's an important point, because as it is, there are lesser number of patients who want to go in for a transplant, younger patients, and the family is ready, like Dr. Vij pointed out. But at the same time, also the surgeons have a hesitancy in putting these pediatric patients on the waiting list, because they feel that anyways, they're not going to get a liver, because the chances of them getting a liver on the pediatric waiting list is very, very low.
Sure. Excellent. I mean, again, two or three key points there. One is that in India, especially, children are less likely to get a DDLT than LDLT. Second is that children are likely to wait longer on a DDLT waiting list. And that by itself is probably going to cause some challenges and people's minds about actually choosing a maybe DDLT option for patients. Now, are there any things that we could do from an allocation perspective to perhaps change this imbalance? Because you know that certain countries have, ring-fenced organs, for example, for pediatrics. From a, say, a national perspective, say a NATO or an allocation perspective, can we somehow correct this imbalance?
So Sonal, just before going to that, I think you'll also put the question forth about extended criteria or DCDs in the pediatric population, because that's something that Heineck spoke about.
Sure.
When we are already on a low proportion of DDLTs in the country, we are further into infancy as regards extended criteria DCD livers. I think that is an important point to make. So there are some possibilities, but there are a lot of fears. So the possibilities are that because there's a growing experience around the world, especially in the Western countries with marginal graft, DCD grafts, machine perfusion, maybe you could use more of these livers. At the same time, there's also recent advances in optimization of donor support. You could use ECMO in the donors in order to get them better. You can do something at the site. For example, you can do normothermic regional perfusion of the donor itself. I think this is going to be elaborated in detail further by Alberta later on. But there are some fears. In pediatric age group, I think there's a general reluctance. There's a concern for size-related complications like vascular stenosis, graft dysfunction for adult recipients. At the same time, the outcomes in pediatric patients if you're going to use borderline grafts. The second thing is that the data for donors supported by ECMO only comes from kidney transplant. There is no data as of now in liver transplantation. And surgical reduction of a DCD liver graft, you're already talking about a borderline graft, and then you're thinking about splitting it to give a part to the pediatric patient and give a part to the adult. So already you're thinking of suboptimal conditions. So if you go to the next slide, I think that when you think about this and you think of extending the criteria in these patients, pediatric liver donors, whatever the current evidence that we have as of now, I think there's some data which was published in 2020, pediatric DCD donors, 17,000 odd DCD donors, pediatric donors aged 0 to 12 years were just about 5%, and about 4.4% were aged 13 to 18 years. And if you look at the recipient outcomes, I think it's on the next slide, Sonal, if you could just go 2 stages ahead. If you look at the next one, so the pediatric DCD, the pediatric DCD outcomes, I think 50 DCD liver grafts transplanted into pediatric recipients has come on as of now. All of these donors were Maastricht 3 donors who were awaiting cardiac arrest. This is a classification that's used, again, a technical term. But if you look at the results here, the patient and graft survival improved when DCD livers were transplanted into pediatric recipients rather than into adults. And therefore, you have to look at using smaller grafts from adolescents into pediatric donors if you really want to get good results in these particular patients. Then coming to your moot question of allocation policy, if you go to the next slide, I think what's important in our country, this is our experience of 300 odd pediatric liver transplants. And if you see that the proportion of DBDs, and I think this is the important part, we just have done one DBD split and one in All India Institute of Medical Sciences, where we also help them with their transplant program among 300 pediatric LDLTs. And even we have used other options like domino living donor liver transplants in order to fulfill the requirement for organs, but not really been able to use a lot of DBDs and splits. So that's our data. And next slide, Sonal, is the allocation that I would propose that we could do some changes. And of course, I need to say that 10 of these LDLTs were supported by the Praveen Agarwal Foundation. We are very, very thankful to them, obviously, to have been a part of our program as well. And on the next slide, you look at some of my suggestions for possible changes in allocation that could benefit to some extent the pediatric population. So I think one of them is, if you have a pediatric DBD donor liver till 18 years of age, the first offer should actually go to a pediatric patient on the wait list, because you're looking for a size matched donation, a size match for the pediatric patient. So probably they should be the first one who should be offered if they have a patient on the list. Second, if you have an ALF patient, acute liver failure patient with no prospective liver donor, probably the priority for DDLT should be given to that particular patient. So if possible, a mandatory split should be done. And again, I should say that, split is not something very simple. A split is a complex operation. So I have to put in the caveat that it should be done when it is feasible. So you need a good quality liver, a stable donor, an experienced operating team. The third point, split liver for a pediatric recipient in young, stable DBD donors. Preferably, it should be an in situ split when you have an experienced operating team available and the conditions are suitable. You need a better coordination in between centers, because you may not have a pediatric patient on the list. Another team in your state may have a pediatric patient on the list. And then you should have that coordination in between teams under the same SOTO maybe for an exchange, if at all, if it is required. And the last part which Heineck yielded to, I think, or alluded to, I'm not sure we are there yet. For borderline grafts for machine perfusion, but probably the way is to test these grafts on the machine and split during perfusion if it is feasible. Beyond that, I think it's too early to say whether we can use these borderline grafts or steatotic grafts or older grafts for pediatric patients as of now in India.
Heineck, I mean, have you done any splits on a patient who's been on perfusion, who's been on a machine?
So we had done proof of concept splits, and we haven't transplanted those, but the splitting on the machine is definitely feasible. And I know that the groups in Groningen and in Italy, they used hypothermic perfusion for during the splitting. So I think there's definitely, these cases has been done. And what is quite important to realize is that there won't be ever a randomized trial with these things. So all the evidence suggests that the machine perfusion is just making livers better. How much better? It's a question, and of course, in pediatric population to do clinical trials is extremely challenging. So that won't be trial. So it needs to be taken on by a center who is happy to push the boundaries, who does have the expertise, because if something goes wrong, it can just stop others following the procedure. And indeed, once the liver is split on machine, as Prashant mentioned, if there was a sharing of organ between centers, you probably can just split it in the pediatric center, take the small bit, and let the major part of the liver travel to other center who can accept the large part of the split, because the machines are just developed for the perfusion of the bigger part of the parenchyma. So I can't see really the left lateral segment to be perfused. But what is quite interesting, and it's probably the last thing I would say, is that the Zurich group just recently published a manuscript, and they kept the liver on machine for up to 7 days. And so what may be in the future that you just take a left lateral segment, you grow it for a bigger child, and you just transplant it to someone who would otherwise need all left liver or something bigger. And even the research can go further on. You can pre-treat the livers on the machine with stem cells therapy or some gene therapy to make sure that kids in the 10 years time may not need immunosuppression. So I think it's exciting space to follow.
Yeah, I think Roberta just chipped in and basically mentioned that they've just published their experience, and certainly we're kind of waiting for to hear that from you as well. I know that you have published your experience on splitting on a machine. I think that's a very exciting thing. So, but again, I mean, 2 points. Prashant mentioned that even one of the largest programs in India, for example, doesn't have a lot of split volume. And we probably do one split a year, although because in Bangalore, we're sort of in between sort of pure north and pure south. So we're going to do a bit of both. And so we don't necessarily perhaps have the degree of experience or the confidence that would come from experience of splitting an organ. Because as you know, if you're doing splits maybe, every week or every fortnight, then you would be much more happier to push the boundaries out. So Vivek, I mean, you have been running a natural experiment of sorts because you kind of are covering geographies that are separate. I mean, do you have sort of any words of sort of perhaps split experience in Chennai and any differences that you see between the north and the south in your practices?
So is this question regarding machine perfusion or over general? Splits. Okay. So, as you rightly pointed out, the experience of split transplants altogether is very limited, even if it's a large volume center. Once we get a donor, first of all, there are many things which play in our mind because most of us work in a private sector, plus for a pediatric population, as I told you, the number of patients who can actually afford transplant are very few. going ahead with a machine perfusion split, this adds to the costs. With a lack of experience, addition of cost, I don't think it's whether it's north or south, it's going to work. That's my personal opinion. It's the first thing first we have to do is, as I told you, awareness and acceptance of the procedure. At this point of time, pediatric population and their parents, they're really not keen to have transplant. I think that is a major problem, major hurdle as far as numbers of liver transplant are concerned. If we see the data of pediatric transplants in India, majority of centers and maximum number of transplants, they do come from certain countries. You can pick up the countries like Philippines, like Iraq. So there are limited number of countries which support pediatric transplant financially as well as their parents also, and then we do transplants. The actual number of transplants in Indian population are very, very few. I don't think so that split liver transplant or machine perfusion is going to work in pediatric population till the time we grow up in our experience of split altogether as well as machine perfusion. North or south doesn't make any difference.
Okay, so we actually have 4 extra minutes by some magical fashion. I must congratulate all our panelists for the excellent job. So I'll just summarize perhaps in about 30 seconds, and then we'll answer some audience questions that have come through. I think as Dr. Vivek has emphasized a couple of times, awareness is probably still a very large part of the battle in India. People aren't aware of transplant as an option. They're not enthusiastic because they don't necessarily see positive role models in terms of outcomes in transplantation. That is perhaps we have some work to do in terms of getting that message out, and that is part of what Praveen Agarwal Foundation has been doing. And secondly, certainly funding makes a very big difference. And places wherever there is access to funding, we see that more people are availing of transplant facilities and people are coming forward to donate. And as Dr. Hynek has actually sort of introduced, he's given a bird's eye view of new technology, machine perfusion, which has extended the life of grafts, also has the potential to modify the quality of grafts so that we can not only preserve grafts for longer, we can perhaps make them better when we actually transplant them. And he's used the analogy of recharging a battery. And certainly when we have a full battery, perhaps we have more chance of reducing it or using part of it for a child. And although there's some very interesting work which will be addressed by one of our speakers who comes next, that's something that will need to be developed. And Prashant has just put this in context for us because he's pointed out there's a wide gap between donor utility in terms of living donor and DDLT in India. And certainly there's a very large waiting list. So that is part of the reluctance of parents to put their patients on waiting lists comes from the fact that the uncertainty of waiting for long periods of time. Again, all our panelists have very rightly said that we perhaps have a few more steps to take before we can take on extended criteria donors for splitting, because we are still not there yet in terms of our experience with split in general, as well as our sort of reluctance to take on things that may adversely impact the outcomes. And even Dr. Hynek has sort of emphasized that fact that we may never see a trial and a gold standard of evidence in that. We kind of will have to rely on incremental experience until we are confident enough to take that on. And some of the allocation criteria that Prashant has suggested are already in place in our guidelines, and I'm part of the NOTO technical committee. We have suggested that some of these guidelines are implemented even on our national criteria. So hopefully we can come across some sort of uniform consensus in what should be done about and I know that the Liver Transplant Society, Dr. Sudhindran, Prashant, and certain other office bearers have also been working on some recommended guidelines that we can submit to our national body. So certainly we will need multi-pronged sort of assessment for this, and hopefully we can address it in a multifactorial fashion. So a couple of questions. First, I think Vivek, I think that if a child gets a liver from a parent, are the chances of complications less? This has come from our YouTube channel from one of the audience who's been asking.
Really not. Really not, because many series, DDLT series, as well as comparison of LDLT, they compare the outcomes and they're almost similar. So I don't think so. If they get liver from parents, then chances of complications are less. It's not like
Sure.
that.
Okay. Dr. Heineck, is machine perfusion done in India too? It's a bitter long story, but I know that perhaps you're best placed to answer that. Mute.
The problem with machine perfusion around the world is the affordability. It's not only for India. I mean, everyone is focused on how much does it cost, but it's only a fraction of the real cost, because the real cost comes with the personnel who is trained and able to run the machines. And even in Birmingham, we were struggling till recently to have a 24/7 cover for machine perfusion. And I think we are, the other centers are just following in the UK. So just to give you an example, surgeons are not happy to randomize marginal liver to ice storage anymore. So that's how well we adopted the machine perfusion, but we still struggle to have a sustainable programs because of the funding. So I think it's global. It's not only for India. I mean, it's expensive technology.
Okay. Next question is for Prashant. If the waiting time increases for transplant, what can parents do? I mean, what are the options available to people?
See, again, I think that DDLT, given the numbers that happen in India, and especially when there is a wide divide in between the north and the south of India, the west is slowly emerging more as a place where DDLTs are happening more often. I think that living donor liver transplantation for them still stands as the first option. And if it is not immediately the parents, that is the first degree relatives, we have to go a little bit distant. If you see in our series also, we had out of the 300, about 82 or 83 of them where the donors were the aunts, the uncles, the cousins. So it has to be that first. So the family has to dig deeper into the family. The immediate family has to dig deeper into the family to basically have donors. As far as the allocation, and again, I'd just like to stress this point in 5 seconds, that if you see number 1, number 2, I said number 1, young livers for young donors, for young recipients. That is number 1. Number 2, ALF, prioritize them. We are too early for splits and normothermic, but when you ask difficult questions, Sonal, I think the difficult answers come in. So if you want to expand in some way, then it has to be via split and via this thing. And the expert teams, I think those who have high experience and, the surgically more advanced teams probably have to take this onus on them to see if they can start, and then they can start transferring this knowledge to other teams to split. So that's what I'd like to say.
Well, we are here to answer the difficult questions, aren't we? Because the easy ones have already been answered. But thank you so much to all our panelists. I mean, you guys have been fantastic. Dr. Vivek, Dr. Heineck, and Dr. Prashant, thank you so much for joining us today. Back to you.
Thank you. Thank you for having us.
Thank you, Sonal.
Thank you.
Thank you so much. Thank you so much, Dr. Astana, Dr. Vij, Dr. Heineck, and Dr. Prashant for such an impactful session. Thanks a lot. We learned so much about donors and the challenges that the fraternity has to face. I'm sure this discussion is going to help the entire pediatric liver ecosystem in various ways. Well, moving ahead to our next panel discussion, I would like to invite Mr. Ayan Chatterjee to take over the next chat, the next talk forward. Mr. Ayan Chatterjee is the head of Sterlite Ed India Foundation and the honorary strategic advisor for TPAP. He heads CSR for Sterlite Power Group as well as Sterlite Ed India Foundation, which is a non-profit organization. His last stint involved leading India operations for Deworm the World, set up by Nobel Prize winners Esther Duflo and Michael Kramer. So we will begin with the panel discussion. And before we begin, I would once again like to request our viewers, our panel members to please stick to the given timelines and wrap up this discussion in 20 minutes. Also, you'll be seeing the timer flashing on your screen 5 minutes prior to wrapping up the session. Viewers, please send your questions in the chat box, in the comment box. And over to you, Dr. Yan Chatterjee.
Thank you, Mayuri. I'm not a doctor, I'm a non-technical person. Greetings to all our viewers and esteemed members of the panel. It is really great to meet all of you virtually amongst us. In the earlier sessions, we all gained knowledge and insights about various aspects of pediatric liver transplants from mostly technical and very distinguished speakers. My effort in this panel will be to make certain efforts around discussion in the non-technicals, but equally important ecosystem aspects. So while liver care advances are happening around the world, there are innovations and support required in the ecosystem as well. The efforts and care doesn't end with a transplant. I think it begins there. Now, how do we promote and strengthen wellness among PLT patients, their donors, and their families? This is our topic today. I have a very capable panel, and I'm positive we will get some ideas through this session's brainstorming. I would basically like to first bring in Dr. Smita Malhotra. She is consultant pediatric gastroenterology and hepatology at Indraprastha Apollo Hospitals, New Delhi. Good afternoon, Dr. Malhotra.
Good afternoon.
She specializes in pediatric liver and gastrointestinal disorders, including acute and chronic liver disease and failures. Dr. Smita is renowned for her clinical excellence in management of patients, and she has written a lot on this also, and also renowned for the academic contribution to the subject. Next, I would like to bring Ms. Srimati Venkatraman as an advocate and guide. She's renowned, and she's enabling food to serve as a medicine. She has been a nationally recognized clinical dietitian for more than 2 decades. She serves as the chief clinical dietitian at Brains Hospital, Bangalore. And she's founded Mitahara. It's available on the web, a patient supporting and information initiative which provides nutritional education for fatty liver and cirrhosis, neuro, bariatric, and diabetic patients. I look forward to getting further inputs on the larger healthcare management of a patient from Ms. Venkatraman. Good afternoon, Ms. Venkatraman.
Good
afternoon. Finally, last but not the least, I have an inspiration on the organ donation movement, Ms. Jaya Jairam. In her official capacity, she serves this panel as Project Director, Mohan Foundation, Mumbai. Under her leadership, Triumph, an initiative organizing transplant recipients and organ failure patients of India, was launched by Mohan Foundation in 2020. It is committed to transforming the patient's quality of life through education, and it has a group of more than 500 patients and caregivers. I look forward to her unique perspective to the matter because she's she has undertaken a transplant herself and can bring in a very unique perspective into this discussion. Good afternoon, Jaya.
Very good afternoon.
So starting off, let's jump in. We have about 15-20 minutes. I look forward to give the audience the interesting ideas which we all 4 of us can bring. Mostly the 3 of you, I will just facilitate. If you look at long-term medical care needed for pediatric transplant patients, it's useful to consider a stronger ecosystem enabling support at various points. Broadly looking at various categories we have in patient support context, there's the awareness part, which Dr. Vij was mentioning quite a few times. The post-transplant processes, diagnostics, consultation, etc. The post-operative complications, if any, and we all know that about 20% or around that figure are post-operative complications come, 1 in every 5 or so. And the long-term sustenance requirements, such as immunosuppressants and other long-term requirements. What are the various ways we can look at this ecosystem strengthening? And bringing in Dr. Malhotra at this point, my particular question will be, what are the opportunities in the ecosystem which can strengthen the long-term medical care for transplant patients and also their families, because we are looking at pediatric transplantation? What are the best practices which you would like to highlight which save time, resources for a patient family? Over to Dr. Malhotra.
Thank you, Mr. Chatterjee. First, may I extend my regards to Mr. Praveen Agarwal. Thank you a lot for all that you have been doing for our transplant patients. I think the biggest, what you said, opportunity is you yourself. People like you are the ones who have made transplantation feasible for pediatric patients and even adult patients in our country. And it doesn't end with just a transplant. It is the beginning. It is the first step. The patient gets a grant, patient gets a financial help for the transplant, but post-transplant also is a very intensive entity. There's a lot of post-transplant tests which are involved. Initially, patients, we do some routine evaluations once the child is discharged. Every week, they go through a series of tests. Gradually, as the time passes by, we increase the time gap to 2 weekly, and then maybe during the first year, it is every month. And usually the first year is the time when they will have the most incidence of complications which are likely after a transplant. Obviously, once they are through the immediate transplant, the major risks are over. But then there are other things which can happen. Rejection can happen, infections can happen. They can develop strictures. Sometimes they may require readmission, sometimes they may require resurgery. So these are the things for which one thing is the family should be adequately mentally prepared, because when they are dealing with cirrhosis or acute liver failure, at that time the only thing they're thinking of is survival. So once that survival is attained, then it is about surviving well and leading a healthy life. So at that step, the first is the mind process, the family being prepared. And then when we transplant babies who have been transplanted by raising funds, then funds come in. So many times we will be, when they require revision surgeries, we'll be doing free surgeries. Obviously, we don't charge consultation fee when they come for follow-up usually. So these kind of patients, we do charity at our part also. But then there will be expensive medications involved. Sometimes a stent placement is required. So what I feel is that some amount post-transplant period also needs some financial support. That may come through foundations, that may come through individual efforts or through family support. So that is one thing. Secondly is the compliance with the immune suppression. That is the most important thing. The family has to understand. And we usually, these drugs are also quite expensive. So we usually support, there are some, usually for the first few months, the pharma companies themselves, we are able to, procure some samples for them or support them through that ways. So regular immune suppression is very important. And then of course, the recovery with good nutrition, good hygiene practices. When we discharge them, we make sure we tell them that there should not be many visitors. They should keep the patients isolated and hygiene. And then these are many factors which are involved in post-transplant care.
Thank you, Dr. Malhotra. So, I mean, just looking at further on this particular aspect, Dr. Malhotra, how did COVID affect your this part of the story, that having visits or having this thing, because you would have patients all across northern India or probably East India also.
Yeah, I would like to comment on that. I think we did not have that much of an impact because most of our patients follow us through email, through WhatsApp by sending the reports. Physically, once the initial 2-3 months are gone by, they do not come that frequently. So that was still feasible. But yes, the routine evaluations were delayed. They did, happen less frequently. And sometimes people sat on their problems and delayed those things. But fortunately, we did not land up much in trouble. What the COVID most severely affected was the funding. The crowdfunding platforms, the amount of fund that was being raised, that was, I think, that became compromised once COVID came in, because there was a lot of funding going towards COVID care and all those things. And I think it led to a resource crunch. There has been an effect, and obviously, yes, things got affected, but the rest of the things, the monitoring and the evaluations were manageable.
And does your hospital and other hospitals have a good system of a rigorous checkup with the patients so that the compliance on the
definitely. All the patients remain regularly in touch with us, whether they are the Indian patients or the international patients. Once they go back to their individual cities or individual countries, they do follow up with their referring pediatricians and the hepatologists over there. But all those things are cross-copied to us. So all regular investigations, they send us, and our inputs, we remain in touch with the local teams. So our inputs are incorporated in the management. So it is always, once a child gets transplanted at your unit, that child remains with you till, for years and years together. So they always, follow up, and wherever there is any complication or anything goes wrong, then also before any major decisions are taken, the team is involved, even if they cannot come here, and there are some interventions which have to be done in their own country. So always a direct coordination with the teams over there is done. And I think every unit must be doing that, not just ours.
Sure. Thank you, Dr. Mehta. I will probably come back to you again. Moving on to Ms. Srimati Venkatraman. Ms. Venkatraman, would you like to highlight the good practices, because you've been there in the whole counseling and understanding the patient needs for more than 2 decades. What are the best practices you'd like to see more of in medical care counseling as well as in the patient community? And are there any support forums, this is the second part of the query, or online resources which you'd like to refer or recommend for patients if they have some questions?
Good afternoon all. Thanks for the opportunity. Thanks, Mr. Ryan. The main thing is malnutrition is present almost 60% of the patient, even in pre-transplants. So it is quite a challenge after transplant, post-transplants, to counsel the caregivers and the parents to ensure that they have nutrient-dense food. The most important is India is such a vast country where 100 miles we have a different cuisine. So we need to understand the home food habits of that particular family, and then counsel them accordingly, and make sure that, because this is a pediatric population, that nutrient dense foods has to be given where we have the proper calorie, protein, not only the macronutrients but also the micronutrients, which plays an important role. Since already that they come with a malnutrition almost 60%, we have to ensure that the right nutrition has to be given, which will help achieve the normal growth and the nutritional status at least within 12 months of post-transplant, where the growth is not compromised, which is very important in this pediatric population. And also we have to take into consideration the behavioral feeding problems in a pediatric patient, because it is not very easy to feed that child due to various reasons. It can be due to lack of appetite or pain or trying to recover. So many things would be there because of medicines. And also, so we have to continuously counsel the caregivers and the families to ensure the right nutrition is given. And whenever they come for follow-up post-transplant, we have to make sure that the nutrition counseling is also done every time they come up, so that the anthropometric measurements and the body composition can be taken. So even if there is a little bit of a fallout, the correct counseling can be done to put them right on track so that the normal growth is not compromised.
Sure. But I'm sure most of the hospital and the nutrition wing definitely counsels this. But what are the more important vulnerabilities which you have seen in the last 2 decades? Where does people often falter?
The most problematic thing is they would have feeding problems on and off, and there would be not enough weight gain, or sometimes there would be too much weight gain. So it would be the seesaw between the two. There are some population where there would be too much weight gain. There would be some where they would not be giving the right oral nutrition supplement if necessary, or they will not have those where the right guidelines. They should not give particular raw foods in that, so that to prevent infection, the hygiene. So it's not just the nutrition, but also where they could also ensure that they don't get any infection through raw foods. So every single nutrient dense food has to be explained, keeping in mind the food habits of the family, so that it is practical for them to follow, and they also try to monitor in a correct way with the measurements also.
So I think what you are also indicating is a lot depends on the nutritionist's own makeup, because the patient family is probably taking the guidance, and the kind of guidance is very essential.
Yes.
What are the resources you would like to recommend? Of course, you also have a resource if you want to talk a little bit about that, as well as what are the other options, because when when a child, for example, is a fussy eater. I mean,
Yes.
and especially when we are looking at a liver transplant, pediatric liver transplant, let's say less than 3 years or something. What are the things which can be useful in this context?
So the main thing is first, the protocol of every hospital varies, but with the doctor's team as paramedicals, so we also have a protocol where during admission, where pre and immediately after transplant, and also when they go home, the proper discharge counseling, and also where we can do, now that it is COVID, people are more comfortable with online. So a food diary can be shared every 3 weeks, every 2 weeks, or a support line where the nutritionist can intervene, saying that this is how you can give a nutrient dense food. He's particularly fussy for the past 1 week, especially in such a small child, like within 3 years, which the scenario is. So we have to give them the correct guidelines to say do's, don'ts, as well as a proper meal plan, enough choices for the family, at the same time not burden the family, so the family foods can be given, which would be make it more nutrient dense.
Sure. Moving on to Ms. Jaya, you have been associated with the organ donation movement and patient support groups for long. What are some of the ways where a support group can be invaluable, you feel?
First of all, it's such a delight to be here. Thanks for inviting TPAF, Mr. Agarwal, as well as Ayan. Such a pleasure to meet you here. To answer your question, I would like to first of all highlight that within the ecosystem, while access to an advanced medical care is there, there are experts, including nutritionists, dietitian. A very important part is the social support network, which is the family and friends, as well as, complementing all of this is the support groups. Okay. And one of the thing that we know that, having been through this as well, we know that having a transplant is literally a roller coaster of emotions. While there is gratitude and there is happiness, but there may be guilt associated with, having a family to also go through a lot, putting a family through a lot. Meri wajah se, my family has to go through this. Or maybe a loved one has sort of gone under the knife to donate one of the kidneys or a part of the liver. There's a guilt associated. There may be guilt associated with that. There may be depression associated with this. Primarily for the patient as well as for the caregivers, in the sense that I see a lot of mothers coming discussing with me, my son, so these are pediatric transplant cases, and my son just doesn't listen to me. He goes out to play. I keep telling him that you have to be under isolation, you have to eat this, you have to do that. So they sort of impose this on the children. It's so sad, but no one is wrong. But the children want to go out, they want to play. Young adults feel that they are just at home. So in difficult situations, there is depression associated with this. Even the long-term medications could be overwhelming for some patients. Some of them actually say, should I just discontinue that? Not probably realizing the importance of what they're saying, that it's a serious matter. You can't discontinue the medications. It's frustrating at times, and then you have to undergo lifestyle changes. You have to be careful about where you're traveling, what you're eating. Is it hygienic? Is it crowded? There could also be anxiety. What if I land up with this situation again? What if the graft fails? Or, very simple things like the couple of months back, we had a couple approach us, and she said the wife had donated a part of the liver to the husband. And after 8 or 9 months post-transplant, the lady actually approached me. She said, can I ask you a personal question? I said, yes, please. She said, since all of these months post-transplant, we haven't even gone and touched my husband. My children are away from him. can we go near him? Can we touch him? So all this is part of the healing therapy. And somewhere, these small things, knowledge is not there. Probably they're hesitant to ask the doctor. Even with respect to diet and all, sometimes the sugar goes out of range. People just want to know as to what works. What have they done? So, being part of a larger group sort of helps the patients as well as the caregivers to share their experiences, to learn from someone else who has gone through a similar circumstance, as well as for others, to just hear out, lend a ear sort of a thing. And this does make a lot of difference. And in fact, a patient support group only complements the rest of the factors in the ecosystem, and it's very much an important, it's part of, I think this is how the healthcare system also evolves, by plugging this gap, by forcing someone to even go go and see the doctor or go and see their dietitian. Kei baar people hesitate. So there's another patient who's saying, no, this is important, you should go and see a doctor. So sort of that motivation is there.
So thank you, Jaya, for this. And I personally know of many patients contemplating, liver transplant, being encouraged by the support group as well as the doctor, as making the right decision. Quickly moving in, I mean, there's so much technology around and so much engagement required in a support group, because it's like a peer group, putting all these inputs in the right way. And patients have a role to inspire others also. So how is your support group, the Mohan Foundation Triumph group, coming along? And there's a question from YouTube audience that how does one enroll in this support group?
Sure. So in fact, we feel that this is probably the way to go. The online way is the way to go, because the reach is much better. It's easier, more cost effective to reach out to people. So probably we'll continue to have a combination of the face-to-face as well as the online ones, especially with respect to imparting the knowledge. It's easier to now invite an expert, and impart the knowledge to people, simply to empower them with the knowledge, so that when they know for themselves, then they can also participate in the decision making. So this is one of our objectives, is to empower the patients with the right set of knowledge. Also, another thing that we see, another way that we see is, now that COVID is the norm, online is the new norm, no thanks to COVID, but it brings the groups together. It becomes easier to reach. It becomes easier to meet on a forum, ask your questions, discuss them out. In fact, just to share with you, we are also now putting in place a new initiative called Get Fit with Triumph, wherein we realize that, a lot of, so all the transplant recipients have to take immunosuppression medications, which do have side effects. And also certain things like obesity, which we discussed earlier, is detrimental. So how do we inculcate the habit? So we sort of have a few inspiring people who within the group who are either liver recipient or kidney recipient, and they do the cycling, or it has to become a routine. It has to become a habit. And so there is a peer buddy who sort of adds on and encourages. So these are some of the initiatives, I think, that going forward we can keep inspiring.
This is wonderful, Jaya. I mean, but just bringing back the question and also the limitation of time, I just have a few minutes. Just how does one enroll? Because there's a YouTube viewer who is
sure. So triumph.org.in, that is Triumph is actually an acronym for Transplant Recipients of India and Organ Failure Patients, a movement to provide hope. That is TRIOMPH.org.in. You can visit there, you can know of our activities, and you can choose to enroll yourself.
Sure. There's another, because of the limitation time, I'm quickly moving on. There's probably a question from one of the YouTube viewers, from Ms. Srimati, that if a child is of a low body weight, is there anything specific you can guide them?
Yes, we have to assess what is their daily nutritional intake, find out where he's lacking. Is it the protein? Is it the fat? And make sure that in between snacks can be given which are healthy, nutrient dense, calorie and protein dense. And also, if possible, prescribe an oral nutrition supplement if necessary, and then try to monitor their weight gain or for the low body weight, and also see what are the barriers why he's not eating, and then try to address the correct points.
Thank you so much. So quickly, highlighting what are the key points. So one is from Dr. Malhotra. I mean, post-transplant financial support is also very important. I think she just stressed on it. At TPAP, we are considering it. We provide some kind of support time to time, and post-operative, complications are also taken care of from TPAP, but there's a larger ecosystem requirement for a financial support post-transplant. I think that is what Dr. Malhotra was highlighting. Compliance with immunosuppressants is key. While the medical, fraternity kind of takes care of it, but I'm also aware that post 3 years, post 4 years, there are certain deaths which happen sometimes because of lack of compliance. So I think this is very key, and we probably need to also integrate technology or some other way where this can be very rigorously monitored. Possibility with a broader connect with pharma companies exists for reducing prices of the post immunosuppressants, because sometimes for pediatric liver transplants, the father is the donor and he might lose the job, and therefore his sustainability and his financial sustenance is sometimes in question. So that needs to be taken care. From Ms. Srimati, malnutrition is present very significantly. I think that's one thing she highlighted, and there are ways to address it, but it needs to be taken care of. And customized counseling, especially taking care of micronutrients, is very important. Jaya mentioned about the advantages of the social network, as well as Triumph taking a lead in this. Congratulations. And also the enrollment details, which is triumph.org.in. With this, I really thank the panel for taking out the time and sharing their experience and ideas. The discussions will keep on continuing. We have, we will keep on reaching out, but the highlights were these, and thank you once again from TPAF. Over to you, Mayuri.
Thank you, TPAF.
Thank you.
Thank you so much, Doctor. Thank you so much, Mr. Ayan Chatterjee, Dr. Smita Malhotra, Dr. Srimati Venkatraman, Ms. Jaya Jairam. Thank you so much, everyone, for your participation in this talk. We have heard about the challenges in this talk from the other side of the story, caregiving and the hurdles the patient and the family has to face long term. Well, thank you so much, everyone, once again for bringing out such important aspect of post-transplant care that are less discussed among the masses. Thanks a lot. And now we will like to move ahead. And I would like to invite Dr. Asthana once again on the screen to introduce our next speaker. That is Dr. Roberta Angelico for a special talk. And she's joining us, connecting with us from Italy. So Dr. Asthana, over to you.
Thank you so much, Mayuri, for this. And it really is a pleasure to introduce Dr. Angelico today. Angelico works as an attending surgeon at the University of Roma. And she's been extensively trained across Italy as well as in Birmingham in HPB and transplant surgery, and has worked in units such as the Queen's Hospital in Birmingham, as well as the Bambino Gesù Hospital in Roma before taking up a current position. Dr. Angelico is particularly well suited for this talk because she has a large experience in both adult and pediatric transplantation. And more importantly, she has actually developed and has been part of an interesting policy that Italy has been put in regarding mandatory splits. And as mentioned in our talk before, we were talking about proof of concept in pushing boundaries forward about using split organs. And her group is actually one of the first groups to do split organs in patients or in grafts that have been preserved in machine organ perfusion as well. So today she's going to talk to us about the effect of a mandatory split policy and the outcome measures which have happened and which have been in place in Italy for the last 5 years. And this is perhaps a very important talk for us from a policy perspective. Thank you so much, Dr. Angelico, for accepting our invitation.
So thank you very much, Dr. Asana, for your kind introduction, and I'm very honored to take part to this conclave and to give my perspective from our point of view. So thank you very much for the invitation. So in my short talk, I will try to show you how is our experience of split liver transplantation in Italy. And of course, it would be a bit different compared to your experience, but probably it will be a good occasion to grow up together. So if you could start with my slide, please. So thank you very much. So as all you know, of course, split liver transplantation starts from a deceased donor. So when we have a deceased donor, we can provide from a single graft, next slide please, a smaller part consisting in a left lateral segment to a children and a bigger part, which is the extended right lobe, at least in the standard technique, to an adult recipient. And this has been introduced in 1988, next slide please, because essentially we had to face the difficulty to find the size match graft for small size recipient, who we know have a very long waiting time on the waiting list and also have a high pediatric mortality awaiting a liver transplant. So the reason why in Italy, as in many Western countries, we had to improve the split liver transplantation essentially is because we have a very few, a small part of living donation, at least in the past, while we have a bigger part of our activity, which is based on deceased donors. So next slide, please. So in Europe, from the European Liver Transplant Registry, as you can see, we had a very growing activity of split liver transplantation, and since 2000, almost 300 of split liver transplant are performed per year. So the experience has been growing in the last decades. Next, please. And for this reason, you can see that in the majority, up to 70% of pediatric liver transplantation are performed by split graft, and a smaller part, consisting in about 30%, are living donation. So this is a good part, which is, I think, very different compared to your experience in India, because at our latitude, at least in Western country as in Italy, split liver transplantation represents still the major source of organs for pediatric recipient. And in the last year, living donation is growing up for children, but is still more based on split liver graft. So for this reason, we put a lot of effort to develop this activity. And to develop split liver transplantation, first of all, we need to define the donor selection criteria. So these criteria which select which donor are suitable for split liver transplantation or not. Our colleague before mentioned this already, and what we can say from the literature is that there are no universal criteria to define which donor, deceased donor, are splittable or not. Each country developed their own criteria, and generally, of course, we prefer to split young donor with low BMI, with normal transaminase, with low days on ITU, and the good donor. But of course, nowadays, these donors are less and less frequent. And at the same time, we need to develop a split liver allocation policy to make sure that this machine works. So next, please. So in Italy, our experience started in the early 90s, and essentially the Italian experience has been based on three major principles. First of all, we wanted to maximize this resource of organs for pediatric recipients. Second, we wanted to develop a split liver allocation policy, which is very important. And at the third part, we wanted, of course, to not give a negative impact on adult liver transplant candidate, because these donors, of course, are also part of the pool donor for the adults as well. Next, please. So in Italy, since the beginning, it has been adopted an in situ split liver technique. It means that the split procedure is performed into the donor in the donor hospital, and these have the great advantage to reduce the cold ischemia time, which is of course correlated with a better outcome both for the left lateral segment for the children and the extended right lobe for the adult, but at the same time it has the disadvantage, at least the challenging of being a very logistic complex procedure, because you need an expert surgeon who goes to the donor hospital to perform the procedure and to split the liver. So in Italy, for example, we have 5 pediatric liver transplant center, and when we have a suitable donor for a split, there is always a surgeon from the pediatric center who travels to the donor hospital, perform the split and come back. So of course, from the logistic point of view, this is something very, very complex and needs a lot of efforts, not only from the surgical point of view, but also from the economical point of view, because the donor can be anywhere in the country. The second important part for us is, of course, to not impact on the adult waiting list as well. So we can choose who is the recipient for the extended right graft, because the right matching between the split graft and the recipient is very important to achieve good outcomes. Next, please. So in Italy, since 2002, we have been adopted a national pediatric waiting list. So as you can see, up to 60% of transplant are performed by split graft, which is the majority. And initially, we had an allocation policy which was regional and interregional. Essentially, when we had a regional donor, the adult transplant center would decide to split or not that liver. And of course, there was a bias, because if the adult transplant center had some pediatric candidate as well, they would split. Otherwise, they were not interested in splitting. So for this reason, in 2015, it has been introduced a national mandatory split liver allocation policy, next please, which essentially is based on the fact that all donors aged between 18 and 50 years old with standard risk. So standard risk for us, it means that there are no risk of disease, of a transmission disease like infection or tumors, are primarily offered to a pediatric transplant center. So the pediatric transplant center will decide if that liver is splittable or not, if we have any suitable candidate for that donor. And this works unless, of course, there is an urgent transplantation on the adult waiting list or a very sick patient like a MELD over 30. So next, please. So based on this new mandatory split policy that, of course, opened and make definitely bigger the selection criteria for selecting a donor for split liver transplantation, we decided, of course, to see how was its effect on the waiting list. And in 2019, we published this experience, and essentially we observed how this new mandatory split liver policy affected the waiting list and also the outcome of graft. Next, please. And to do this, we compared the first 2 years of this mandatory split policy with the previous one. And we observed that since the introduction of a mandatory split policy, we could maximize the donor resource, and the split liver transplantation rate increased up to 84.4%, which is kind of higher compared to what is reported in literature. In other Western countries, the split rate is about 2%, like in the UNOS registry. We reduced the waiting list time. The median time for us is 3 months and 2-3 days for urgency, and the pediatric waiting list reduced to 2%. But all this was maintaining a priority for adult sick liver transplant candidates. So the adult center were not so worried to accept this mandatory split policy. Next, please. In terms of outcomes, we observed that we had similar outcome of split graft in the new split liver allocation policy compared to the old allocation policy. And this was observed both for the left lateral segment in children, but also for the extended right graft. So I believe this is a very important part because to set up the split liver transplantation program that works, we need to involve absolutely the pediatric center, but also with the adult transplant center. And they need to be convinced and happy that that graft will work well. So this is something very important. Next, please. And we also analyzed the kind of donor that we splitted because we use a very wide criteria. And we saw that despite the expansion of split liver transplantation donor criteria, most of split procedures were performed anyway in very young donors, which means that we had the possibility to choose the best donor for our recipient and to make and optimize the donor recipient matching. Up to 39% of suitable donor for split liver transplantation actually were not used because we had a lack of size match recipients. So this is, I think, a very important part because there is a pool of donor which is not negligible that we could split, but we didn't use because we had not recipient. Next, please. So probably this kind of deceased donor could represent a pool graft, for example, for a not conventional split technique, like a split full right, full left, which provide two bigger parts of a graft. And those are very good grafts, for example, for adolescent or small adults. And we know that adolescents, at least at our latitude, they wait longer for a graft. So and we need always to take in mind that we have a part of this donor that could be reallocated and used in other ways. So of course, this kind of technique is more challenging. So our proposal nowadays is to try to do this in excited technique and on hypothermic machine perfusion, because as I was mentioning before, and Dr. Mergenthal very well mentioned and explained it, is that machine perfusion, especially hypothermic machine perfusion, could be a very good platform to increase the split liver transplantation, because in this way we could combine the benefit of an in situ split liver transplantation and ex situ split liver transplantation. I mentioned more hypothermic machine perfusion because those are most of the time very good grafts, so we need just to prolong the preservation time. And I was anticipating before we performed our first case of split liver procedure during an hypothermic perfusion, and that was a very good experience, and we could transplant the both graft, one in a smaller, very neonate, and the other in an adolescent graft. So next, please. So the outcome of split in Italy, it's this figure. So I think it's quite good. At 10 years, we have a patient survival of 84% and the graft survival of 73%. Next, please. And if you compare this with the living donation activity, because at your latitude, you have more activity or living donation, those are the outcome. So in Italy, we started more consistently living donation since 2008. It still represents a smaller part. We use mainly in these patients, like in metabolic liver disease, these patients that have a longer waiting time. But as you can see, patient survival is similar, and there is a slightly inferior graft survival, but it is expected, of course, like in literature, because this is deceased donor. So in the next slide, I will just share with you my conclusion to say that the use of split graft permit to achieve excellent outcome in pediatric liver transplantation. And it is very important that the maximization of split liver allocation policy, when integrated with the living donation living activity, almost eliminate the pediatric liver transplant waiting list mortality. So the split liver program needs a continuous adoption of organ allocation rules, because it's essential, the organ allocation, and this needs to be done accordingly to the changing of the donor population and adult liver allocation. And in our experience, almost 40% of donors which were potentially split were not used for a standard split procedure. So this pool of donors could represent a graft resource, for example, for adolescent or small adults awaiting a liver transplantation. So I thank you very much for your attention, and I'm happy to take any question. Thank you.
Thank you so much, Dr. Angelica. That was fascinating. That's, it's very unusual to see good policy that has been implemented and see sort of direct results of it after a period of time, which is perhaps the best way in which we can measure how, how we have actually impacted people. So there are 2 or 3 key messages that probably are relevant to us. One is that we need to see every organ as not 1 but 2 organs, So like for our kidney patients, we know that there are 2 kidneys, but normally we do not psychologically see 1 liver as 2 organs. And that when you talked about the splitting for the adolescents, I think that's an important part, either the left lateral or the left, we take a decision and then we can actually help more people. And the second, which is the very key point for me, is that even with your, extensive experience and the confidence that has been built up in Italy, 40% of organs, of splittable organs, are not being utilized. So I think that we are probably 2 steps behind you, because we are still at a point where organs or units are splitting organs if they have a potential recipient. It's not when they are looking at a larger regional or a national interest. And that certainly has become a bit of a challenge for us. So some of the questions that had come in while you were sort of giving a talk were, one question was about, is there a national policy in India? I can answer that. Unfortunately, there is no national policy in India for splitting. And currently, as part of our, advisory committee, we have recommended that people should actually ask the question for splitting at least, rather than, although it's not mandatory, but at least there is a required ask every time a splittable organ comes on. So I think that if you had a message for, say, for India, we have an excellent living donor program, and you've yourself shown that the results of living donor are perhaps better than deceased donor. What should we do from some sort of your sort of external view?
So thank you for the question. So I think that, of course, so the reason why we implemented so much split liver transplantation was because we had no other choice. So, of course, we needed to maximize the deceased donor pool, and we could maximize a very good result. So at the end, what happened in Italy was that we had so good result with split liver transplantation, and the living donation activity had the slowing growing because, we didn't have so much need. In your case, of course, it's different because you are in a different situation. Living donation is absolutely the bigger part, and I strongly believe that if it is possible, a living donation for a children is the best choice. Of course, if you have a donor, we always offer a living donor. And as you have definitely more experience than me in living donation, but parents most of the time want to donate, so it's kind of easier to find a donor. So my experience is that when you have a living donor, a possibility of living donation, you always need to perform a living donation because the results are better. So we know this. Of course, if there is not any possibility of living donation, then a split liver transplantation is a great opportunity. And to do a split liver transplantation, you need, first of all, to know that there is a donor, because this experience of Italy, it's a long experience. Initially, the mandatory split policy was shared only in the north of Italy, in the northern region, and just later on it was expanded in all the nation. So probably even just starting in some regions and between some center with experience of splitting, it could be a very good start. And because you need to start at the beginning with the smaller number, and the second part is not only that it needs to be mandatory, but you need some skills to do the split. So of course you need to trust your colleague, that you will receive a good graft for your recipient. So when you start this kind of program and you have a few centers, it's easier. So in Italy, we could do this because we are only 5 pediatric transplant center, and we of course work in the same way. So if one of my colleagues from Bergamo in northern Italy go to Split, it will be the same if I go by myself. So this is something very important. So my message is, when you can, always living donation. If it is not possible, split liver transplantation. And for set up this, you need selection criteria for the donor, and the wider they are, the better it is, for my point of view. And second, you need a standardized surgical technique.
Sure. I mean, thank you again for that. I think you've echoed some of the points that Vivek, Heinek, and Prashant had made about sort of selection criteria and doing it in centers that are high volume. Thank you so much again, Dr. Angelica, for your time. I hope that we can continue this conversation in some of our other Liver Transplant Society meetings as well. Thank you.
Absolutely. Thank you very much for the invitation. It was a pleasure.
Thank you. Bye. Back to you, Mayuri.
Thank you so much, Dr. Roberta. Thanks a lot for sharing the insights on liver transplant policy in Italy. It was an eye-opener for all of us. Thank you, Dr. Astana, for leading the session. And now, ladies and gentlemen, we are moving ahead, and now I would like to invite our guest of honor, Mr. Sonu Sood, an actor, a humanitarian, philanthropist, and a man with many hats. We are proud and thankful for his association with us, and past few years, TPAP and Sonu Sood Charity Foundation have been working together on many occasions, and we hope to take this association further in future. So now, without taking much time, I would like to welcome him on screen to share his thoughts and wisdom with us. Hello, sir. A very, very warm welcome to you.
Yeah, hi, everyone. Thank you so much, and apologies for maybe my network. And since I'm traveling, I just landed from Chandigarh, and but it's great connecting with you, and I'm sure I'll be able to know more great people who have been saving lives together, and it's always a pleasure connecting with the family of Mr. Praveen Agrawalji, and the kind of vision he has, the kind of work that he has done always inspires me also. And together, yes, we were able to save many more lives, and we promise to keep continuing doing that. But I think the biggest learning experience from the whole pandemic for all of us is that yes, you can make everything happen. You just need that the thought to make it happen, and rest the prayers of the needy. Do the magic. So I think whatever little I've been able to do, it's all because of the prayers and for great associations like Praveenji and many more who are today with us. So thank you so much, and I promise that I'll keep on giving my 100% to change many more lives. But yes, miles to go. The journey's on.
Well, thank you so much. Thank you so much, sir, for taking out time from your busy schedule. We really appreciate your presence and support extended towards TPAP. Well,
I just want to add one more thing if I have
sure,
time for that. I remember when the first time I spoke to a lot of people from the association, Praveen Agrawalji and everyone. So the biggest lesson that I learned from them was that there's only one mission, that is to bring a smile and to save a life. And there are hundreds of people who come to my house every day with their reports, with the complications that they have in various medical challenges. And when we show them, okay, we'll make that happen, and the kind of relief that you see on their faces, I'm sure you guys have been experiencing since many years. But yeah, this is new for me. From past 2 years, I've been doing that. But I always say that whoever we have today on the platform, let's make this happen. We have to make this platform, this voice so big that anywhere, anyone in this country should feel that there's someone who's there to help you. We just need to reach out to all of us, and we will give them a new life. So I pledge today that, yes, I'm there for all of you, and I would really be honored that if we all can come together and bring many more smiles.
That's so kind of you. Thank you so much, sir. We really appreciate your presence and the support extended towards TPAF. Once again, thanks a lot. And now we are moving ahead, friends. We have a special pre-recorded talk by Dr. Anil Jalan on setting up a screening program for pediatric liver disease. Dr. Jalan is a Chief Scientific Research Officer at NIRMAN, that is Navi Mumbai Institute of Research in Mental and Neurological Handicap Metabolic Clinic, Navi Mumbai. His expertise is in clinical and lab aspects of newborn screening, critically ill newborns, and molecular diagnosis of various genetic disorders. He has training in metabolic medicine from 10 European universities. Well, Dr. Jalan has many publications to his credit and has authored several books. So without further ado, I would like to begin with the special pre-recorded talk by Dr. Anil.
Okay, so good morning, everyone. So today's talk is screening for liver diseases, especially metabolic liver diseases. And what I'm going to discuss is two types of metabolic problems associated with liver. One is where you actually have a liver disease and the liver structure or architecture is disturbed, the liver cell function is disturbed, and therefore you may need to consider treatment targeting towards liver disease, which may also include liver transplant. There is a second group of diseases where you have involvement of liver because of the enzyme function. That means liver is the primary source of enzymes and the abnormalities, but the liver structure is normal, liver cells are normal, and you may treat these disorders with specific medicines or diet, those are available. But if there is no response, you may also consider transplant of the liver, which may be auxiliary or orthotopic. So I'll just take two cases to illustrate my this view, where whether the liver is the primary seat of pathology, and second, where the liver is not primary seat of pathology in terms of architecture and liver cell function, but just one isolated enzyme which is not functional. So let's take this case number one, which is YP, 2 years old male child, born out of third-degree consanguineous marriage. He presented to us with history of failure to thrive, irritability, delayed development, hypotonia, rickets, but there were no history of seizures or jaundice. And this family has lost 2 previous children with suspected liver disease. So this was a case where there was a liver pathology expected. The basic investigations, like any other case of liver or metabolic condition, we start with CBC, which are okay, liver function, which are abnormal. And then we performed various different profiles like galactosemia, tyrosinemia, bile acids, ferritin, oligosaccharides. And we'll talk about those things later, but just let's see the tyrosinemia profile. What does it mean? We screen for disorders or condition which is called tyrosinemia type 1. And we have certain tests in that, which includes PBG synthase enzyme, succinylacetone in blood, succinylacetone in urine, plasma amino acids, and couple of other things. So here we have abnormal succinylacetone both in blood and urine. Blood is high 38, urine is 296. And therefore the diagnosis is very straightforward, that we are dealing with tyrosinemia type 1, where you get succinylacetone elevation. Now, the standard line of treatment is NTBC, which is of course available, but is a costly affair, and we need to import it. That's the biggest problem. And second is we give low protein, high calorie diet with tyrosinemia formula. That means low tyrosine amino acid supplement. We need to do correction of acidosis, supplement calcium, vitamin D, and multivitamins. But most of the time, it so happens that this line of treatment is inadequate or is not fully effective if it is started, say, after 1 month of life. Now, this child has presented to us at the age of 2 years. Now, this is when he presented, and we, of course, started with NTBC, and within 6 months, he showed beautiful recovery. We kept on following this child up, and by the age of 10 years, we realized that this child has liver pathology. That means there is a cirrhosis, there are 2 tumors, and on further evaluation, it was found out that he has hepatocellular carcinoma. At the age of 10 years, he was suggested liver transplant, and total liver was replaced, and mother had given her liver, and this child is doing very well after that. So post transplant, even though slightly there is elevation of succinylacetone, his liver function and otherwise liver structures are okay. His diet does not need any restrictions. Now he does not even need NTBC, and his life is settled, very good condition, no issues after that. So this is one type of pathology where the liver is involved, and you get abnormal liver function, abnormal liver structure, and conditions like tyrosinemia, which may go into hepatocellular carcinoma. So this is one disease, and which really requires a good liver transplant as early as possible if NTBC is not available, or somebody who cannot afford NTBC for a long time. Now, this condition is quite common in India. We have seen at least 50 or 60 cases in last, say, 8-10 years. So this is not at all rare. And in newborn screening, we do recommend to screen for tyrosinemia type 1, and we do by succinylacetone in dried blood spot, not by actual urinary succinylacetone, which is a diagnostic test, confirmatory test. So for screening, we use dried blood spots. Let's take a second case. This is a 1-month-old female child born out of third-degree consanguineous marriage. Full term, cried immediately, birth weight of 3.5 kg, developed lethargy, vomiting, seizures from day 7 onwards, and she had urinary ketones positive. Other basic investigations like ammonia, lactate, sugars were normal, and there was no metabolic acidosis. So initial screen like DNPH test and TMS showed leucine metabolite and keto acids, and therefore there was suspicion of MSUD, maple syrup urine disease, and confirmation was done by GCMS, gas chromatography mass spectrometry, which shows a very typical pattern. And this is the child, she came to us at 7 days, and this is, I think, somewhere around 1 year, and she was doing very well on diet. But this is one condition where liver structure is normal, liver function is normal, but the seat of abnormality is the enzyme deficiency which is there in liver. And this child was offered liver transplant. And after, say, I think 1.5 years, this child was transplanted. And after that, she's doing very well. No need of any diet, no seizures. She did have some complications after liver transplant, but then after that, she settled down. So this is one condition again, which is like a metabolic disease presenting with, say, seizures or abnormalities, but not liver pathology. That means liver function is normal, liver structure is normal, yet she gets benefited with liver transplant. So these are the disorders. Similar to this, you can consider urea cycle defect, and there are so many other disorders where you may start thinking about offering as a liver transplant, treatment as a liver transplant. So this is one case, MSUD, where you get burnt sugar-like odor, abnormal leucine, isoleucine valine, and GCMS showing 2-oxoisocaproic acid. So this is the GCMS that we see. We will not be discussing pathology. Just one point I would like to highlight. If you see abnormalities of leucine, isoleucine, valine and TMS, please confirm with GCMS, because documentation of these metabolites in GCMS is very important. Screening is different, diagnostic test is different. So now let's talk about what we do for screening. Now, when we have a patient with suspected liver disease and probably due to metabolic disorders, you can have hepatomegaly, there may be jaundice, there may not be jaundice, liver cell dysfunction, ammonia lactate and other basic stuff may be abnormal, but not necessarily abnormal. So having this kind of combination with or without hepatomegaly, with or without jaundice and kind of liver cell dysfunction, you plan to investigate. Now, this is what we call diagnostic approach. You plan to investigate for inborn error of metabolism. And which are the disorders to be considered? There are many, but I recommend about 8 to 10 disorders which should be ruled out. Galactosemia, tyrosinemia, fructose aldolase deficiency, fructose 1,6-diphosphatase deficiency, neonatal hemochromatosis, mitochondriopathies like respiratory chain defect, Niemann-Pick disease type C or even A or B, congenital disorders of glycosylation, CPT1, HLH syndrome, and there are few more like bile acid synthesis disorder and even urea cycle defect. They can have liver dysfunction. So now the point comes is, how do we screen? Diagnostic approach is different. When you have a case already presenting at 2 years of age and you don't have any plan for screening all the disorders, you know what you want to do, like diagnostic test, that's a different approach. But when we plan for screening, the approach is little different, and we have to find out the disorders which are common in our area or in our country where you need to do screening tests. So you can select for galactosemia, which is fairly common and there is a good screening test. Tyrosinemia, there is a good screening test. You can also look for certain conditions like CPT1 or some kind of respiratory chain defect. But then the margins for diagnostic test and screening test will get blurred. So what we do is, whenever there is a symptomatic child, we perform what we call metabolic liver profile, and this includes generally first step galactosemia screening, because that's a treatable disorder. Most of the children will respond to dietary restriction of lactose and galactose beautifully, and if you do it very early in life, probably you will not have any complications. That means the child will be neurologically normal, most likely no cataract, and the development should be fine. So what we do is we start with total galactose and galactose 1-phosphate. We can also do thin layer chromatography for sugar and Galvan-Put enzyme. With the combination of these 3 or 4 things, we can identify the type of galactosemia, that is either galactose 1-phosphate uridyl transferase or galactokinase deficiency or UDP epimerase or mutarotase. There are 4 types, so these can be easily detected and then confirmed with molecular studies. Second disease which we always recommend for screening as well as diagnostic approach is tyrosinemia. It's fairly common. Sorry. And what we recommend is doing blood succinylacetone by dried blood spot, which is a good screening test. And for confirmation, you can always do urinary succinylacetone. PBG synthase and plasma amino acids, those are helpful in further understanding the pathology. And if we start treatment with NTBC, we can also do NTBC level. Third condition, which we always try to rule out, is HLH. This is not HPLC, sorry, this is HLH. And where we do soluble CD25, serum ferritin, LDH, cholesterol, and triglyceride. Again, this is a, you can say, treatable disorder, needs aggressive treatment. And it's one condition where you may have to plan bone marrow transplant rather than the liver transplant. So the treatment is totally different, but presentation is hepatic. So these are the 3 primary diseases which we recommend to screen and to use for diagnostic approach in any case where you have liver pathology. conditions where you may not have actual liver pathology, that means the structure looks okay, the liver cell function is okay, can be fatty acid oxidation defect, urea cycle defect, and some other conditions like MSUD. So we do TMS, dried blood spot TMS, and we can also do NEFA, that is non-esterified free fatty acids, beta hydroxybutyrate, urine ketones. And for urea cycle defect, we do orotic acid, plasma amino acids, urine amino acids. So these will pick up disorders like MSUD or urea cycle defect or some cases of fatty acid oxidation defect. Bile acid synthesis disorders can be screened. For that, we need bile acid isomers. Generally, it is done in Europe, which is not routinely performed in India. We do total bile acid, but after that, we need help of these kind of specialized labs. Storage disorders where you may have liver pathology like Gaucher or Niemann-Pick type A, B, or C, where you need screening by ketotrioxidase, CCL18 or oligosaccharides, and then enzyme analysis, after which you need molecular studies. So this is a diagnostic approach, but from this you can derive screening approach also, depending on what you want to screen. As I said, for screening, galactosemia, tyrosinemia, and urea cycle defect, MSUDs, these should be the primary targets. What samples are needed? If you want to do metabolic liver profile, that means a diagnostic approach, 2 ml of heparinized blood, 2 ml of EDTA blood, 2 ml of or 3 ml of serum, 10 to 15 ml urine. All these are, you can say, enough for doing all these investigations mentioned before. If you're planning only screening, that is by dried blood spot, either 2 ml heparinized blood or dried blood spot, 4 good sizes, 3 by 8 inches circle is good enough to screen for galactosemia, tyrosinemia, and fatty acid defect, some amino acidopathies like MSUDs or citrullinemia, arginenemia. All those urea cycle disorders, those can be detected by dried blood spot screening. Additional studies may be required because we are not covering everything. There are so many diseases which can affect liver. So for CDG screening, we may need transferrin isoelectric focusing, bile isomers, as I said before, we may need leukocyte enzymes, plasma sterols. Peroxisomal disorders, if suspected, we may need very long chain fatty acids, plasmalogen, pipecolic acid. For Wilson disease, we may need serum and urinary copper and ceruloplasmin. Of course, genetic studies are nowadays must to confirm the diagnosis. So you may need NGS, whole exome sequencing, whole genome sequencing, and now the new technique which is coming up, transcriptomics. At times, liver biopsy may help, light microscopy or electron microscopy. So it's a good idea to keep glutaraldehyde in your hospital. If you want to send electron microscopy, you don't have to wait. 3% glutaraldehyde is a very good carrier for the tissue. So this is the approach what we use for any suspected liver disease case. What I shown a bigger profile is a diagnostic profile. From that, we can select something which we want to screen for as a routine. That means any child who comes in or a newborn where you want to rule out like tyrosinemia, galactosemia, fatty acid defects, amino acidopathies, urea cycle defect. One single tandem mass spectrometry with a good 3 by 8 circle spot will suffice. So this is my take on the screening and diagnostic approach to metabolic liver disease. Thank you.
Thank you so much, Doctor. Thanks a lot for sending across this video, this recording. And with this talk, ladies and gentlemen, we conclude today's webinar. I hope you all enjoyed this knowledge-filled session as much as we enjoyed hosting it for you. I would now like to invite, I would like to request Mr. Praveen Agrawal to come on screen to deliver the vote of thanks. Sir, welcome back.
Thank you, Mayuri, once again. And friends, so this brings us the end of such wonderful discussion today. It was a pleasure to have you all connected through this webinar and discuss the current developments in the field of pediatric liver transplants today. I'm hopeful that the discussion will help immensely to improve the outcomes of pediatric liver transplant in the future. Concluding our fourth edition today, ALTC 2021, I would like to express sincerest thanks to our chief guest, Mr. Sonu Sood, who honored us with his presence today. His support means a lot to us, and we are looking forward to work closely with his foundation in near future too. I'm grateful to all the panelists, speakers, moderators, and the delegates for taking out time from their schedule to participate in this webinar, connecting with this across different time zones and share such gems of wisdom. I'm also thankful to Dr. Sonal Asthana for his valuable contribution in curating the conclave and his constant support to TPAP as an advisory board member. I'm grateful to TPAP medical expert panel members, Dr. Ashay D. Cruz, Dr. Sanjay Rao, Dr. Neelam Mohan, Dr. Anurag Shrimal, Dr. Bipin Vibhuti, and Dr. Lalit Verma, who gave us their valuable time to provide guidance on clinical matters all the time. I thank the dignitaries of Rotary clubs in attending this event. Last but not the least, I would like to thank Mr. Ayan Chatterjee for his strategic insights, TPAP team, event management team, and all the volunteers from the Sterlite family who have worked tirelessly to connect with all of you and make this event a success possible. TPAP looks forward to having you all and many more at its next conclave in 2022. Thank you, dear. Till we meet again in person, stay safe, stay healthy.